Hi guys, this is my clinical update and case study. I did it on sepsis. So here's just an outline of my presentation. The clinical update will include terminology, anatomy, normal physiology, pathophysiology, traditional practice recommendations, current recommendations, and multidisciplinary considerations. The case study itself will include the admission of the patient to the hospital, his medical history, medications and supplements given in the hospital, significant lab values, vital signs, consultations and procedures, the ADIME process associated with this case, as well as the progression of care, and personal comments from myself. So here's the review and clinical update. I did it on the immune system because that is a system primarily involved with sepsis. So the immune system has two parts, the innate immune system and the adaptive immune system. The innate immune system acts as a physical and chemical defense against pathogens. Innate immune cells recognize pathogens and phagocytize the cells, as well as release cytokines to attract other innate immune cells to the site of infection. The adaptive immune system is mediated by T and B lymphocyte cells, which recognize pathogen antigens through memory from the innate immune system and destroy the pathogenic cells. Sepsis occurs when the body undergoes an extreme inflammatory immune response due to an infection, and this could be bacterial, viral, fungal, or parasitic, but it's usually bacterial. Cytokines are proteins that mediate and regulate immunity and inflammation. They act as communication cells, and so when an infection occurs, they signal other immune cells to come to influx that area of the body in order for an immune response to take place. An inflammatory response is an influx of fluid along with the immune cells when pathogens are discovered or tissues are injured. So here's a picture of the anatomy of the immune system. The tonsils and thymus make antibodies which fight pathogens. The lymph vessels carry lymph fluid throughout the body, and lymph nodes filter the lymph and get rid of the blood cells as well as the pathogens that the blood cells have phagocytized. Bone marrow produces white blood cells. The spleen is similar to the lymph nodes in that it removes old or damaged blood cells, and white blood cells fight pathogens. The normal physiology of the immune system includes the prevention and limitation of infection by recognizing the body's own cells and then attacking non-self cells. So just to go a little bit further into the innate immunity, innate immune cells use receptors to recognize patterns associated with viruses, bacteria, and fungi, and they respond quickly and broadly. Inflammation is the typical response, and the innate immunity actually activates adaptive immunity. So the main cells which are a part of adaptive immunity are B and T cells, they're lymphocytes. They recognize specific signals rather than patterns. Their random regeneration of these cells allows them to recognize new antigens constantly, which is important and keeps our immunity up. And this adaptive immunity also utilizes a system of checks and balances to prevent unnecessary activation. So it checks for self cells rather than non-self cells so that it doesn't attack itself normally. So the pathophysiology would be sepsis. And sepsis occurs when an infection, usually bacterial, leads to a systemic immune response. So there's an excessive activation of antigen recognition and inflammatory response, which leads to multi-system dysfunction. This dysfunction leads to impaired tissue oxygenation, which ultimately exacerbates the process and causes a huge inflammation response and more organ dysfunction. So here's just a chart from the Nutrition Care Manual that shows the stages of septic response. The first stage is the systemic inflammatory response syndrome, SIRS. And so the definition of this would be fever, tachycardia, tachypnea, and organ dysfunction. So then the next stage is sepsis. So this occurs when SIRS is present, but also a source of infection has been identified. Severe sepsis occurs whenever sepsis may be diagnosed as well or along with at least one organ dysfunction. So that could be the heart, lungs, brain, any organ. And septic shock, which is the final stage of the septic response, occurs when sepsis is present along with hemodynamic instability. So just to go a little bit further into severe sepsis, because that's what my case study actually is on, along with the confirmed infection, two of the following must be present: a respiratory rate greater than 20, a fever greater than 101 degrees or body temperature less than 96.8 degrees, or a heart rate greater than 90. So here are the traditional practice recommendations that medical staff would actually take care of. The antibiotics should be infusing within 1 hour of sepsis recognition. And these need to be broad spectrum IV antibiotics so it can take care of any pathogen that may be in the patient's body. Fluids should be administered intravenously to assist with hypoperfusion, and they should be administered at 30 milliliters per kilogram within 3 hours. Vasopressors may be necessary when sepsis is occurring, and the target mean arterial pressure should be about 65 millimeters per mercury, with norepinephrine being the first medication attempted as far as vasopressors go. And finally, mechanical ventilation may be required. The tidal volume of 6 milliliters per kilogram should be the target. And here are the current evidence-based practice recommendations for nutrition, and I got these from the EAL. Enteral nutrition support should be chosen over parenteral nutrition support unless contraindicated. And it could be contraindicated because of hemodynamic instability, bowel obstruction, high output fistula, or severe ileus. So anything that would keep us from using the gut. And RD should suggest initiation of enteral nutrition within 24 to 48 hours after the injury or admission to the ICU. For patients on the ventilator, small bowel feedings are recommended over gastric feedings, and this is to reduce aspiration and ventilator-associated pneumonia. Finally, at least 60% of the total estimated energy requirement, which is determined by the registered dietitian for that particular patient, should be delivered to the patient within the first week of hospitalization. So here are some multidisciplinary considerations. The physician is obviously important. Reading doctor notes and medical charts is one of the most reliable ways to actually get information on your patient. And going to interdisciplinary meetings, which I'm required to do every day at my facility, is crucial to obtaining the latest updates and progress that your patient may be experiencing. Nursing staff are another great source for getting information on your patient. They are working hand in hand with your patient, so anything that may not be in the patient's chart, you can usually get from a nurse. And finally, pharmacy. There are certain medications which may interact with foods, and so it's important to talk to the pharmacist to make sure none of these interactions are going to occur. Okay, so here's my case study, and it's Mr. L. He was admitted October 3rd. He's a 75-year-old male. He was admitted to the hospital with a primary diagnosis of severe sepsis. This was caused by bacteria, pneumonia specifically, and he had secondary diagnoses of respiratory failure and AFib. He was admitted to the intensive care unit, and he was intubated on admission due to respiratory failure and CO2 retention. He also had extensive cellulitis on his right foot upon admission. So his medical history includes arthritis, AFib, COPD, hypothyroidism, prostate cancer, type 2 diabetes, and peripheral vascular disease. So medications and supplements he was put on in the hospital: vancomycin, which is an antibiotic that was used to treat his sepsis. Lasix was used to get some fluid off of him. And he was also on heparin, insulin, vitamin C, B12, a multivitamin, and IV fluids infusing at 75 milliliters per hour. The only the food-drug interaction noted are alcohol with Lasix and heparin, and that was not an issue while he was in the hospital. So the most significant lab values for Mr. L were glucose, because he's diabetic, and BUN and creatinine, because he actually experienced an AKI while in the hospital. So upon admission, all three were high, and they were October 3rd was his admission, and they remained high until October 12th. So the only one that actually lowered into normal limits was his creatinine level. And here are his vital signs throughout his stay. His heart rate, temperature, respiratory rate, and blood pressure. His respiratory rate was especially important because he has COPD, and he had respiratory failure upon admission to the hospital and had to be put on the ventilator. So that was especially important. Some consultations and procedures he underwent while in the hospital was a chest x-ray to confirm his pneumonia infection. He had a nephrology consult to determine the need for dialysis after he experienced an AKI, and it was indeed needed. He was intubated and extubated due to respiratory failure. He had an RD consult, of course, to calculate a tube feeding for him, and then he had an NG tube placement and removal. So the role of the dietitian was to assess and determine the patient's needs for calories, protein, and fluids. Also to determine the type and rate of tube feeding he would need, and to monitor his progress for any dietary changes. So here's his nutrition assessment. This information was gathered from the hospital and doctor office medical records due to intubation, so we obviously couldn't talk to him and get this information. And the consult was ordered by the physician because he needed a tube feeding. So he's 75 years old, he's 5'11". His most recent weight prior to admission to the hospital was 225 pounds, and that was on September 30th. And then his weight on October 4th was actually 241 pounds. So that was a huge increase in weight due to the fluid volume. His BMI, using his current weight of 241 pounds, was 33.6 obese, and we used his adjusted body weight to calculate his needs based on a BMI of greater than 30. He had edema present. Cellulitis was also present on bilateral lower extremities. His blood glucose levels were elevated, especially on admission, they were 172. He was NPO due to intubation at the time of the assessment, and visually the patient appears overweight. After extubation, we actually got to talk to the patient. He was actually, when we spoke to him, he was eating lunch and he was having difficulty propping himself up. He was very obviously weak, and there was notable wheezing when he answered questions, so you could tell he was having difficulty breathing. He states that he is compliant with a diabetic diet and he did not wish to have any diabetic education, but he does eat 3 meals a day along with snacks between his meals, and he pairs proteins along with his carbohydrates. But his wife usually prepares most of his meals or snacks. So for his estimated needs, we adjusted his body weight due to the BMI of greater than 30, and we got his adjusted weight to be 90 kilograms. So because he was obese, we decreased his caloric intake to 20 to 25 calories per kilogram. So we got about 1,800 to 2,200 calories per day. For his protein, We used the normal range of protein because he had a new AKI and was going to receive dialysis. So 72 grams to 90 grams per day was the protein needs that we estimated. And then for fluids, we kept the fluids on the lower end due to fluid accumulation. So 25 milliliters per calorie per kilogram is what we used, and we got about 2,200. So he actually had two diagnoses. The first was inadequate intake related to intubation as evidenced by NPO status. So for our intervention, we were collaborating with the healthcare team to ensure that the patient was receiving adequate IV fluids, but not too much that it would cause more of a fluid overload. We monitored and evaluated food and beverage, and our goal was for the patient to receive adequate hydration through IV fluids while NPO. Our second diagnosis was involuntary weight gain related to acute renal failure, as evidenced by BUN of 93, creatinine level of 5.89, edema, and a weight gain of 16 pounds since admission. His intervention for this diagnosis was to collaborate with the healthcare team to reduce fluid accumulation by not overhydrating the patient. We monitored and evaluated his weight change, and our goal was that his weight will remain within acceptable range for the patient to receive dialysis. So he actually did receive nutrition support. On October 5th, the physician requested a tube feeding recommendation because the patient is diabetic and had been NPO since 10/30. So that was a 48 hours NPO. And we recommended Glucerna 1.2, a continuous feed with a goal rate of 65 cc's per hour, 1.56 liters. The tube feeding provides 1,872 calories, 93.6 grams of protein, and 1,256 milliliters of water. So that wouldn't quite reach his fluid estimated need. So we also included 100 milliliter water flushes to be provided every 4 hours for an additional 600 milliliters of water. And the beginning rate of his tube feeding we recommended to be 30 cc's with an increase of 10 milliliters per 6 hours, or every 6 hours as tolerated. So the progression of care, on October 3rd, the patient was admitted and intubated. IV fluids and antibiotics were infusing. On October 4th, the patient presented with acute renal failure and required dialysis. On the 5th, the tube feeding was initiated. On the 7th, the patient was tolerating tube feedings well, and the rate was advanced as planned without complications. On the 8th, the patient was actually extubated. On the 9th, a PO diet was initiated, and it was an adult medium consistent carb diet, which provides about 1,800 calories a day, so it was right at his estimated needs. On the 11th, he received dialysis, and the patient was tolerating his PO diet without complications. His intake was fair at 50%, which could be because of the dialysis. He probably wasn't feeling well, so he wasn't eating 100%. On the 12th, his PO intake is good at about 75% of all meals. I actually took the patient's dinner menu order for that day, and he stated that he was very excited about the chicken pie. He was hungry, so that was great. On the 13th, the patient is medically stable and was actually discharged from the hospital with PO antibiotics. The healthcare team, which was a part of his care, were physicians, including the hospital physicians themselves and a nephrologist, nurses, the dietitian, respiratory therapists, social workers, and care coordinators. So just some personal comments from me about the case. Mr. L improved quickly despite his critical condition upon admission. He was only in hospital for 10 days, and his length of stay was complicated by intubation, dialysis, and tube feedings. So I actually thought it was really incredible that his length of stay was only 10 days because of all of those complications. Severe sepsis affects many, if not all, of the body's systems and can affect nutritional needs greatly. So Mr. L experienced sepsis-related organ dysfunction of the lungs and kidneys, which required us to estimate his needs a bit differently as far as calories and protein. So yeah, it was really clear that sepsis affects nutritional needs. Mr. L's prior diagnoses of COPD, diabetes, and PVD, and obesity also further complicated his nutritional needs, so it was really a great learning experience to have this patient. Upon discharge, Mr. L's lab values and vital signs were near normal, with only the creatinine actually being within normal limits. So his appetite had returned and his bacterial infection was under control, so his physician felt that he was prepared for discharge. And he has not been readmitted to the hospital, so I think the doctor made a great choice. And I'm thrilled that the case resolved with good outcomes, but I'm aware that this is not the case with all patients. So I feel like I was very lucky to see a patient's length of stay that was so complicated actually ended up correcting itself, and he had a good prognosis at the end. So here are my sources, and that is it.